Tēnā koutou katoa, ko Janet Titchener aho. I've only got 10 minutes, so I won't introduce myself. 20 or 25 years ago, we only thought that there were two types of diabetes, type 1 and type 2. But we now know that there are more than 50 different types of diabetes. Indeed, the current literature would suggest that over maybe 10 to 15% of those who are labelled as type 2 do not have type 2 diabetes, and about 3 to 5% of those labelled as type 1 do not have type 1 diabetes. It's important that we recognise or identify these patients, not only to ensure that we give them the appropriate and safe management, but also here, of course, in New Zealand, that they have access to the management options that they're entitled to. Unfortunately, there is no straightforward way for us to identify these different types of diabetes, and my goal today is to review the typical features of type 1 and type 2, along with those of the more common atypical types of diabetes, so that you may easily recognise some of what I call the red flags to suggest that you have got an atypical diabetes sitting in front of you. Type 1 diabetes, historically, we have always thought of as a child's disease. However, we now know that that is wrong. Over half the people who get type 1 diabetes are over the age of 30. The oldest I've ever diagnosed with a new onset of type 1 diabetes is an 87-year-old. We've also historically thought of type 1 diabetes as being the skinny person's diabetes, and type 2 diabetes as being the large person's diabetes. However, we've got an obesity epidemic, and 30% of our population are either overweight or obese. You can be obese and get type 1 diabetes. In other words, what I'm trying to point out here is that you can no longer sit and look at a person and by their age or their size determine what kind of diabetes they have got. Diabetes is also considered, type 1 diabetes is also considered an autoimmune disease. The theory is that the person is born genetically set up with the propensity to get the disease, and then somewhere later on in life there is what we call an environmental hit, which we believe is probably some kind of infection, a viral infection. When that environmental hit occurs, somehow the immune system revs up that genetic background and turns the genetic switch on, and the immune system starts to attack the pancreas. In a child who gets type 1 diabetes, that immune system is extremely powerful. The pancreas doesn't just sit there, it fights back, but it's not very strong. There is a bit of back and forth that goes on, and we call that the honeymoon period. It lasts about 6 months to 18 months, but eventually it settles into an equilibrium, at which point the immune system is so powerful that the person is essentially left with imperceptible insulin production. In an adult onset of type 1 diabetes, however, it's quite different. Their immune system is not very powerful, their pancreas is quite strong. There is the same back and forth with a honeymoon period. That honeymoon period is anywhere from 7 to 15 years. At the end of that honeymoon period, the person is often left with some background insulin production. What I've got up here on the slide is what we classically see in a textbook as the description of type 1 diabetes. The person is supposed to be presenting symptomatically. As I've just explained, an adult will not necessarily present symptomatically. We often pick them up on our screening tests. I've also suggested in the textbooks that there's a lack of metabolic syndrome, in particular a high HDL or a good cholesterol profile. And on the most part, this is true. However, as I mentioned earlier, we've got a problem with obesity in our country or in the world, and they do not necessarily have a metabolic syndrome. There's not usually a strong family history with type 1 diabetes. However, there may well be a personal or family history of other autoimmunity, which is a red flag. And of course, there are the usual blood tests, which I won't take the time to go through. Very different from type 1 diabetes, type 2 diabetes, on the whole, the patient presents asymptomatically, and indeed they don't know they've got it, and that's why we have screening tests. Sorry, turn the page. The underlying pathophysiology is the peripheral insulin resistance that is associated with central obesity or the metabolic syndrome. And indeed, I'm going to point out here, the importance of the unfavorable cholesterol profile that goes along with the metabolic syndrome, notably a low HDL. The formal definition of type 2 diabetes is peripheral insulin resistance and a low HDL. And there are the other associated symptoms with metabolic syndrome. Also, unlike type 1 diabetes, type 2 diabetes tends to have a family history. And this is due to shared genes, which we have found, as well as shared lifestyle. It's no surprise that any pathology that results in a reduction in pancreatic function is going to cause diabetes. Things such as cystic fibrosis. Up here I've got pancreatic cancer, a bad one to miss. Okay, or we're also very good at creating diabetes by giving people medications such as high-dose prednisone and isoniazid, the early HIV drugs, and today the modern biologics. The one I want to focus on is the one in the middle, however, pancreatitis, gallstone pancreatitis, alcoholic pancreatitis, obesity-associated pancreatitis, high triglyceride pancreatitis. Nearly half of those who experience pancreatitis in their lifetime are going to go on and develop diabetes. This is not type 2 diabetes. This is pancreatitic diabetes. Unfortunately, the pathologies that contribute to the development of pancreatitis are almost identical to the pathologies that contribute to the development of type 2 diabetes. So there's no surprise then that around 30 to 50% of those who develop diabetes following pancreatitis are misdiagnosed as type 2 diabetes. It's even more concerning when you consider that the global incidence of pancreatitis has more than doubled since 2006, and New Zealand is sitting at the absolute top of the global incidence rate. And indeed, Māori are almost 2 times more likely to develop pancreatitis than a European New Zealander. Asians and Pacifica are not far behind Māori. So you can see that there is a propensity for us to misdiagnose Māori as type 2 when indeed they have pancreatic diabetes. A couple of points that I would then like to make here is that a person who presents with chronic rumbling pancreatitis, maybe even acute pancreatitis early on, is a person who's presenting with symptoms that mimic bowel cancer or gastric issues. And often what I see is somebody who's gone for a mega workup for colonoscopies and upper endoscopies to rule out colon cancers and other gastric issues. The workup comes back as negative. The person is put on high-dose omeprazole and told they have type 2 diabetes, a big red flag for somebody who really just needs to be put on a little bit of Creon and a little bit of insulin, and their symptoms will go away. The other thing I want to say is that, of course, we've now got all of these new medications, liraglutide, dulaglutide. Please do be confident that you've got a person with type 2 diabetes sitting in front of you before you are prescribing these medicines that are contraindicated in pancreatitis. The next most common type of atypical diabetes after pancreatic diabetes is probably the group monogenic diabetes. Many of you will remember these as the MODIs, okay? They account for around 2 to 3% of everyone who is diagnosed with diabetes before the age of 25. The 3 most common of these, GCK, HNF1 alpha, and HNF4 alpha, require very specific treatments, and indeed GCK is a diabetes that requires no management whatsoever. So you can understand why it's important that we actually suss out these people. Essentially, as the name implies, monogenic diabetes, one gene has gone wrong in the family. This gene is handed down in a dominant fashion. And so the kind of history that you get is, oh, everybody in my family's got diabetes. Oh, some of them have got type 1, some of them have got type 2. Oh, I had this aunt who had type 2, but then it got changed to type 1. So you get this very muddled but very strong family history of multiple generations of diabetes. The textbook description, as I've put up on the slide here, suggests that the diagnosis occurs at a young age. However, we have missed so many of these people that we are very much finding people in their 50s and 60s who are parts of families who have got monogenic diabetes. So in summary, what I'm hoping is that very quickly I've given you a flavour of these different kinds of diabetes, but that in fact there are red flags that you should be watching out for those that you've got in your clinic who've been labelled as type 1 and type 2. The red flags for type 2 diabetes would be somebody who's got that title but has a high HDL, or unintentional weight loss or ketones, no associated metabolic syndrome, personal or family history of autoimmune disease, and a rapid progression onto insulin or a low-dose insulin, 10 units of Lantus, and it's well controlled. They don't have insulin resistance or peripheral insulin resistance. And then the red flags for atypical type 1 diabetes, of course, negative antibodies, negative ketones, and strong multi-generational family history of diabetes. This is a talk that usually takes me about an hour to go through. I hope that I haven't confused you more than anything in the 10 minutes that I had, and that I've given you something to think about when you're looking at your patients, understanding that anywhere from 15 to 20% of your patients who are labelled as type 2 do not have type 2. Thank you very much.